So welcome to your patient today. This is Lucy. She lives in assisted living. Obviously, she doesn't look like she's in the best state of being right now. She fell when she was coming to the bathroom to brush her teeth, and she didn't come down for breakfast. So you went up and you checked on her. When you say, Lucy, Lucy, are you okay? She kind of groans, and it's just like, So what I want you to do is I want you to take about 10 or 15 seconds, maybe even pause this video at this point, and work with Lucy and think about what are your priorities? What are your priority concepts? So not only are you putting in your priority concept, but you're also then coming up with the why. Why did you pick this? Don't get stuck in the interventions. Take a moment to pause and think about the science behind why you're picking that intervention. All right, so let's get started with what are we doing for her? What was your first priority? Well, safety should be up there, right? Safety should be huge. Why am I worried about safety? Well, there might have been something dangerous in this. Maybe there's water and maybe she slipped on it. And if we don't take care of that water quick with a towel or blanket or something, we might slip on, fall on it too. Another thing is that you can see that she's got some blood, albeit it is my coloring job, but so then there's the safety for us, and we need to make sure that we are being careful with that blood exposure, right? I mean, I don't know her very well, so we're paying attention to the safety that's going on. We might also want to make sure that we're safely handling her. So whether it's body mechanics of getting her up, or we're worried about that spinal cord safety and we're holding her C-spine or something like that. That's what we're going to be thinking about. As we're thinking about Lucy and her safety, what kinds of now interventions? So if we're worried about the danger, we need to fix the danger, right? So if there's water on the floor, if there's, I don't know, a jaguar or something that was attacking her in her bathroom, which probably would never happen, but you never know. These days, it's 2020, weirder things have happened. So, but we need to fix the danger. Whatever that danger is, we need to fix it, or we need to find a way to be safe. With Lucy, not so much an issue, but with, if you're out on a scene and you see somebody fall with a head trauma, we're going to need to make sure that we're taking care of that danger. Whether it's we're in the car and we're in the middle of the street, we need to be safe before we enter that scene. The blood exposure, we need to make sure we're being safe with blood exposure. Not that a blood is our priority at this moment, but we don't want to get anything. So this is why we wear gloves. Think about why you wear gloves. Sticky, gooey, wet, not yours. You need to make sure you're wearing gloves. So that blood exposure, we need to put on gloves. And then safety handling her. So when we're talking about body mechanics and if we get her up, we need to make sure we're using the appropriate equipment. If we've got it, we need to make sure we're moving her slowly. We talked about C-spine. If we're worried about a spinal cord injury, things that would help us assess that spinal cord injury would be if her hand grasps, right? Asking her to follow commands, that kind of stuff, which leads us right into what is our next priority concept, and that's cognition, right? We want to make sure that we are taking care of her cognitive status, like what happened, because she's obviously hit her head. We probably have blood either from the mouth where she hit or a bloody nose or something like that. So we need to make sure we've definitely have some sort of head impact. So cognition, we've got head impact that we know about. We've got, we want to check if there's swelling. And how do we check if there's swelling? Like if you have a sprained ankle, you can see the swelling. If you have a patient that's fallen, you can't see the swelling and if that's happened. So how do we see swelling? How do we assess swelling? Well, we do that with our LOC, where we already said she groans, so we probably don't have a great LOC right now, right? Our level of consciousness is definitely different than what it's been. So a change in LOC. I maybe, those hand grasps. Again, when you're coming into a scene, it's not like you check one thing at a time. You check several things at the same time. They each tell you something different, but like when you come into a scene and you're like, Annie, are you okay? When you do your CPR, right there, you check cognition. When you check if they groan, they're breathing. If they don't groan, we got to now check breathing. And so now we're going to check pulse and breathing, right? Look, listen, and feel. You check multiple things at once. So it gets kind of interesting when we talk about priorities, because sometimes the priorities overlap, but really you're definitely checking in an order. So our hand grasp, is she able to wiggle her toes, right? I'm not going to be asking her to lift her legs or necessarily push against my feet. But I am going to be asking her, if she can maybe feel me or any of that kind of stuff. I'm definitely going to be paying attention to that. The next thing we'd want to talk about is we've got some perfusion issues, right? Because we've got blood on the ground. So why do I pick perfusion? Because we have blood on the ground, so we definitely have some sort of issue. Maybe perfusion is why she fell. I'm wondering why she fell. Did she fall because she had a syncopal episode and because her heart isn't functioning or pulsing real well? So why did she fall? I want to kind of know, and that could definitely be a perfusion issue, as it is commonly for our elder population. Then that's going to lead us right into what are our interventions. My blood, I want to make sure that I'm assessing where it's coming from. Oops, I changed that color, didn't I? I want to assess where it's coming from and the volume, because we could get ourselves into a hypovolemic shock. Usually not with our head injuries is that a big, huge concern. It's more of a it might happen, but something to pay attention to. So blood, we're going to be definitely assessing that. I may want some vital signs, because we're talking about why did she fall. So I may want some vital signs to figure out what's going on and why we fell. Again, we're kind of bouncing around with this. Another one is gas exchange. And these two, perfusion and gas exchange, kind of overlap, right? Because airway, breathing, circulation are all important. And they kind of overlap with their priorities. Gas exchange, I want to maintain her airway. She groaned at us, so we knew she had an airway. But, we're definitely going to want to maintain that airway that's going on. Now, because we have a bloody nose, that also can impede our airway. Right? Think about when people get bloody noses. I know on TV they show them pinching the bridge of their nose and putting their head back. That is actually not what we want to do with patients, right? Because if we put their head back, where is that blood going? Again, people with non-science thinking minds, they'll just try and put pressure on it and stop the bleeding. But we have to understand that bleeding is still happening. Also, she might be on some anticoagulants, so that bleeding may continue to go on, and then we have bigger issues. So if we're impeding that airway with the blood, that becomes an increased challenge. So if this is why I picked gas exchange, again, I'm probably wanting to do those vital signs. Think about, I'm doing respiratory rate, I'm doing my pulse ox. With perfusion, I'm doing my blood pressure, my heart rate, right? So those are definitely my vital signs, kind of things that I want to look for. If I'm maintaining that airway, maybe I'm leaving her on her side instead of rolling her to her back, because that blood, I know I want it out, not in. If people get blood down in their stomach or in their lungs, bad things happen. Either we aspirate on the blood and then we have other issues, or we vomit the blood from our stomach, and that can cause so many problems. So when we're working with Lucy, we really want to make sure that we're helping her. At some point with her, I'm probably calling 911 because I need more help, or I'm at least calling some charge nurse after I've kind of stabilized. The big things with head traumas is just like with any emergency. We need to recognize something has happened, okay? Like when I said, she didn't come down for breakfast. So what happened? And in my brain, I'm like, well, maybe she just overslept. Maybe she was just really tired. It's independent living, so they get to do whatever they want, right? And then I'm going to stabilize what I can. When I stabilize, I need to be able to assess each one of these priorities. Otherwise, I'm not going to understand what I'm stabilizing and why and what I need to look for. The other thing that I'm going to do is I'm going to ship her. I'm going to get her to where she needs to be. When we're talking about head traumas, so with Lucy, with stabilizing, right? We want to decrease swelling. That's our goal. And then we want to, oh my gosh, I'm having a brain fart. We want to decrease swelling and decrease, maybe I'm having some brain swelling, decrease stimuli. So again, like if her husband's in the room and he's freaking out, we probably need to calm him down. We need to make sure that we're calm until we get her. Now, it's really hard when you're calling 911 to get the decreased stimuli, but if she were to not have to go to 911 and maybe she just has a concussion injury, we need to make sure that we're turning down lights slow. Maybe we're bringing dinner to her instead of her coming to the dining room. Maybe we're making sure that we're assessing her more frequently. I know with a lot of people, they say we got to wake them up, right? We're not going to wake Lucy up every 15 minutes. We want her to rest. Rest is when we heal. And when we wake people up, we are creating that stimulus. All right. And so think about that. How do I decrease her stimulus? I let her sleep. Now, we're going to want to make sure that we're doing Q2-hour neuro checks or Q1-hour or whatever the doctor's ordered. You are going to follow your doctor's orders here. You might even check on her more often. You don't need an order to check on someone more often. And so maybe you're checking on her or having a CNA check on her every once in a while, and then you're checking every other hour maybe. But we have to rest to heal, but we have to be able to be woken up. If we can't be woken up, then that's showing us that we have that increased swelling. Becomes a really big problem. So when you're working with Lucy, safety is always our first, then cognition, and then perfusion and gas exchange. It just depends. If she is not breathing well, then gas exchange is going to top perfusion. If she's not, if she's bleeding a lot and we need to get that bleeding stopped, maybe perfusion bumps up in the priority list. But those ones kind of interchange depending on what's going on with your patient. What I want you to think about as you're working with this patient is, what is the worry about the head being injured? What is one of our big concerns that we need to be worried about with our head trauma patients? And that is seizures. When we start talking about seizures, seizures are a huge issue with our head traumas. And why are they such an issue? Well, think about it. You have the brain, and it's swollen or irritated from the trauma. And now I think of seizures as like AFib in the brain. So you have an electrical current that is not able to get to where it should or needs to go. And that's when we see seizures happening, is when the electrical current in the brain is not functioning at the normal path that it normally would. So priorities with seizures are safety. We need them to be safe. And when I say safety, that means these are people that are going to have massive muscle movements and spasms, inherited tonic-clonic or grand mal seizures, any of that kind of stuff. Safety becomes a huge issue. We need to make the space as safe as possible, whether that means we have seizure pads in the room and on the bed, not pillows. Anything floating in the bed could become a suffocation hazard, and we really want to make sure that we're not causing suffocation for our patients. That kind of would be counterintuitive and bad. So we want to make sure we are really keeping them safe. We want to get them to the ground if they're in a chair. If they're in a car, we want them to pull over. It's really important with our seizures. Airway, we want to maintain an airway as much as possible, but do not stick stuff in their mouth. Okay, I know in movies they show spoons, they show belts, whatever. Do not stick anything in their mouth. They have a clamping power with their jaws that you would like shock a shark. So do not put anything in their mouth. They will clamp down on it and they will cause a lot of problems. And now you have a foreign object in their mouth while they're seizing. You can give them oxygen, but it's not going to do them any good until they actually take a breath. You cannot force a patient to take a breath who is having a seizure. I'm sorry, you can't. This is why people die. People die from hypoxia from prolonged seizures. All right, the lack of oxygen to the brain then causes more seizures to happen and then causes just kind of a cascade of events. I had a guy that seized for 3 days and he ended up dying from just mass hypoxia of the brain because we could not get the seizures stopped. And he'd probably been seizing for like a couple days at home. Drugs are bad, guys. Don't do drugs. The other thing that we really need to pay attention to with a seizure is time. When did it start? What did they do? And how long it lasted. So we want the time. How long did it last? And this becomes really important because as we're working with these patients, if they're having problems after the seizure, really long seizures, they'll go into what we call a post-ictal phase, which is afterwards they're really, really tired. And we're gonna, in that space, that's when we give them their oxygen and maintain their airway, turn them to their side, all that kind of stuff to keep them safe. But that's kind of after the seizure. During the seizure though, we need to know how long it lasted because we need to know how long of a hypoxic period that they had. So that's something to really dig into when you're working with your patients. The other thing is chart what you see, okay? Because I had a nurse one time that she charted that a patient had a grand mal seizure and then called the family and told them that this patient had a grand mal seizure. The patient had no history of seizures, had no problems with seizures. And so then I went back and I dug into her charting. Mind you, the family from Texas is on their way up. They're nervous, they're scared. Their loved one is probably not, going to make it in their mind, all this kind of stuff. I went back to her charting and I read what she said, and she said, it was at 2 a.m. Her and the tech were going in the room to, do a bed check and get them on clean pads and clean dry pads. And they pulled back the blankets and he stiffened up and he put his arm out straight. That doesn't sound like a seizure to me. That sounds like a patient who is not happy that he's being woken up at 2 in the morning and stiffening up and just kind of almost like spasming. The other part that really got me concerned about that she charted it was a grand mal seizure is she said that after they were done, he asked for cheese and crackers. These patients, after they have really big seizures, they're not going to want to eat. They're very sedated. They're very exhausted. It is like running a marathon in 3 minutes. I mean, people break their arms having seizures. They break ribs because their muscles just clench down so hard at a rate and a speed that is just almost non-human. So very sad that the family all came up. He didn't have seizures. He basically had you woke me up out of a dead sleep, and he stiffened up and he braced himself when they tried to turn him. So chart what you see. Don't chart, don't diagnose, don't say he had a focal seizure or whatever. Say, had a seizure in the left arm or had spasms in the left arm that lasted for 30 seconds, and then the right arm and the left arm continued to spasm, started to spasm or whatever you see, chart it. I don't care if it's in formal language or not, but do not chart that the patient had a grand mal seizure without describing it. Remember that interpretation of data versus data. You want to give clear data, let other people interpret the data to what they realize and assess that it is. So with our seizure patients comes a lot of medications. We want to pay attention to these meds because they become huge priorities, because if these patients don't get these meds, we're going to run into some really big challenges with them. So I'm going to give you some names that you're going to want to make sure you look up and understand. Keppra is one that we use. Tegretol is another one that I see pretty often. Another one that's kind of in the Tegretol family is the tripedal. Okay, and these are probably their trade names because they're easier to say. Ativan is one. All the diazepams or all the benzos, so diazepam, which is Valium. I think I've seen some clonazepam, all those kinds of things, all can be used to treat seizures. Dilantin and Depakote is another one. So you're going to want to make sure that when you're looking, what's a no? When you're looking at medications, what is their goal? What is the goal of all these meds? It's to decrease the CNS. It's to decrease that stimulus in the brain and the electrical current. The problem with that is there's so many parts of our body that are that need our CNS, our central nervous system, to work. And so things like low blood pressure, sedation, all of these things. So we get a lot of patients that don't like their seizure meds. This is one reason why we're having a lot of issues with the marijuana laws, is because people are finding that marijuana actually has some really good use with our seizure patients. I'm not advocating for marijuana. I'm just saying that that's something you may see in your career building up, is because there are a lot of really good anecdotal studies and some research in Australia to show that marijuana does actually genuinely help. I know at the Med Center, when I worked there, we in Colorado legalized marijuana. We lost a lot of our seizure kids to Colorado because even they just would take the chance. I mean, you're talking about kids that are having seizures, 100 seizures a day. Even if it cuts them down into half, it makes their life just so much more valuable and quality initiated. But it decreases that CNS. The other thing is we want to make sure these increase in priority. So if you have a patient that is not wanting to take it, or maybe you have a patient that's been made NPO for a surgical procedure or a small bowel obstruction, we need to make sure that they're getting these meds. If they're not getting them their normal oral route, we need to make sure that they're getting them either IV or through their PEG tube or something. We actually had, when I worked at Bryan, we had a situation where the patient was made NPO, probably for a small bowel obstruction or potentially some procedure or something, and he did not receive his anti-seizure meds for 3 days. On day 3 or halfway through 3, he ended up having a massive seizure and dying. So who do you think got in trouble for that? It was the nurses, because no nurse actually called the doctor to let him know that we hadn't been giving him, or like to clarify, like, hey, you don't want me to be giving, saying he's NPO, but his seizure meds are all, oral. So we probably need to switch these over. We have lots of ways of giving these meds. It's really important that we give meds, we prioritize these meds, but we also look at things like blood pressure and stuff like that, because that can become a huge, huge issue. Seizures, thank goodness, I don't see them a lot, but we do see them, especially with our traumatic brain injury patients. So thinking back to Lucy, making sure that we're getting her to where we need to, we're decreasing the swelling and decreasing the stimuli. And if she has a seizure, we're documenting, we're keeping her safe, we're keeping her airway as much as possible open, kind of just going. And then we're making sure that we recognize the time that it's going. Hopefully this kind of helps you put together some of this information. I know it's a lot, and it's kind of a crash course. So keep digging into it. Make sure to review your book, and make sure that you're taking some time to really dig into the patho, because the patho will let you know the treatments that you have to do.